Good morning. Good morning, everyone. This is another edition of the Mayor's Emergency Response Roundtable. I'm Rick West, Mayor of Chesapeake, and I am glad you joined us today. I think I speak for everyone when I say that we all wish that this COVID-19 was a thing of the past and that we could move on and talk about better subjects. But here we are in the 5th month dealing with it once again. And before we get going on this topic, I do want to let you know that today we are taping this on the morning of July the 28th. It is my understanding that the governor will be making some announcements later today, and we're not sure, but we're hearing rumors that there will be tighter restrictions. But that's okay. The things that we talk about today, I think, will apply regardless of whether we're in phase 2 or phase 3. But we will stay tuned for later to find out what he will have to say. So with that said, I would like to welcome my guest, who is no stranger to anyone who's been following this pandemic. Here, our local health director, Ms. Dr. Nancy Welch. Welcome, Nancy. Thank you so much. So let's get right to some of the concerns that we're hearing about. We know the numbers are going up. Can you explain what it means when we say cases are rising? Now, a lot of people think the rise in cases is only because there's a rise in testing, but we know that's not, in fact, a direct correlation. So can you explain that?
Yeah, that's a very legitimate question, and certainly a question I get a lot of times. So let me just sort of share some information. I have a slide, if we can put that on, that shows the weekly case rate per 100,000. And this is for Chesapeake, it's not for the Eastern region. And what I want to note about that is, number one, we have a denominator per 100,000, which is sort of a standard way that we mathematically make it so that every location is as if it's a city of 100,000 people, because then you can compare Eastern region or Norfolk or Virginia Beach and do a comparison, so it's legitimate. And what I want folks to see from this slide that's most important is that we had a flat curve. You can see where it's flat, so the rate, this is the is a weekly average rate of cases, and it's been mathematically per 100,000. You can see where in June it was like 20, it was flat. But then when it opened up, it was explosion. And you can see the large increase. Yes, it is true that we did increase testing at that rate. More testing was available. Previously, it was just for those who had symptoms, but then it was opened up. But here's the thing about testing and percentages. If the testing only found the ones that were already out there, in other words, there was no increased surge in transmission, it was just these people were positive, and as we increased testing, we found them. Then you would expect the percentage of those who are positive to remain the same. For example, say we tested 100 folks, 10 were positive, that percent of positive would be 10%. Then say we tested 200 people. Now, if you don't have a surge of transmission and you're just finding those who are already out there, you would expect to also have 10% or 20 people. But as you can see from this graph that we've shown, there's a surge, an absolute surge. And this can only come from having an increased transmission of the virus from one to another. And our percentage of, again, positivity, this is cases, percentage of positivity from test has gone from around 5% up to 14%. And if you look at the Eastern region, we've had an increasing rate of positivity and cases for 45 days, and the states had for 37 days. So there is a definite difference in terms of the Eastern region and the state. And for Norfolk, Virginia Beach, and Chesapeake, you can see the graph change when we opened up.
So if I remember correctly from my statistics class, the more people you do test, or the more people that are in a sample, the more accurate that percentage is. Is that correct?
Ooh, and you weren't even a math teacher, were you?
I just had to take the class.
I just had to take the class, right, and you listened.
I did.
And you're absolutely right, and that gets to prevalence issues and how prevalent something is in the community. And so, yes, as we test more, the numbers are more accurate. Of course, our dilemma right now is that we've been so good at testing more that the labs are overwhelmed. And so the amount of time it takes to get the lab results back is
Right, that's
kind of
what
long.
we're hearing too, that people are hoping for 2 days, it's generally a week or so before they're getting the results. Yeah, the first thing I do every morning almost is look at that percentage, and like you said, we were at 5 point something at one time, and in the last several days, or maybe last week or so, it's just been hovering at that 14. Went down a little bit, came back up. I think yesterday was a little higher. So I look at that every day just to see where we're going. So let's talk about the young people. That's what we're hearing, that the increase. The big part of that is because of the 20 and 30-year-old. How is that group impacting the rate of infection?
Yeah, I have another slide that can show you. And this is a slide, if you look at the different colors, the 20 to, well, let's look at the 20 to 49-year-olds. They're the yellow and the maroon color. They're the ones that have surged. And again, the surge is totally consistent with when we opened up. And this is the weekly cases by age group. So it's sort of extracting from the previous slide, but breaking it down by ages. And so it is certainly showing that the big contributor to this increased percentage is this 20 to 49-year-old. Now, it is also true, and we're getting some more information that actually is extremely helpful. We've always thought of, and to the most part they still are, the 20 to 49-year-old are generally speaking asymptomatic. They are the spreaders. You may remember several years ago, I think it was 2009 or so, when we had H1N1 flu. At that time, our children were the spreaders. That's where we saw it. And so we did mass immunization in the schools in order to help stop that spread. But the spreaders now are, interestingly enough, not so much the children. The spreaders now are these 20 to 49-year-olds because they don't have symptoms, generally speaking. They don't seem to be ill. They're also the ones that when it opened up, they socialize more, they're in bars, they're in social gatherings, in large groups. So people then sometimes respond, but we're not seeing an increase in the death rate, and there's truth to that. When you have this kind of an age group or even asymptomatic type group that is contributing to the main increase, you really don't expect to see the impact on deaths or even hospitalizations necessarily for what we would say is 2 to 3 transmission cycles, and that means 4 to 6 weeks, because 14 days is considered the incubation period. That is because it has to get outside the social circle. It gets outside their social circle where it gets to people who have a spouse who is diabetic, or they visit a grandparent. So it gets outside the circle and gets to those who are at risk. So I think in the not too distant future, we're going to start seeing that impact because we're already seeing some of the impact. Actually, if you go to the next slide, this shows it's in the eastern region, not just Chesapeake. But it's a very good follow-up to the slide that we just had showing the 20 to 49-year-old age group. Back in March, 28% of the new cases were in that 20 to 49-year-old age group, but now it's 60%. So it's a definite shift. And back in May, the median age of positive cases was that 50-year-old and to 69, that we associated it with the older population. Now, the median age is 30 to 39 of cases. So we're definitely having a shift. And what we're waiting for, or expecting, I should say, not something that we necessarily want, but something that we're waiting for, is when it gets outside that social circle. when it gets to the vulnerable population, because they're the ones who have severe illness, and they're the ones in the hospital. I would tell you that a number of the hospitals are already beginning to feel that pinch in terms of increased demand on their services. I have one other slide I would like to show, and this, there you go, thank you very much. This is what's called the surveillance slide, and again, you can see it's looking at the different regions, and I know a lot of people say, well, why do we have all this emphasis on the eastern region? This slide tells it all. This is where, again, you with the red, and you can see we are an outsider, not the kind of outsider I'd like to be, because of our increase in cases. So all of this information is very concerning, and it's definitely something that we need to understand and decide to do something.
So let me ask you a couple of questions about the death rate and so forth, or just one about death rate. Then I want to talk about the virus itself, the effects that it has on individuals, and I know that's not part of the script, but we often are hearing that the death rate is not nearly as bad as the common flu. I know I read the other day, I think 15 million people worldwide have died, and I'm not sure how that would compare. Do you have any information?
Mayor, I didn't even prompt you
I
on
know.
this. That was great.
Okay. Good,
I
good.
just happened to have a slide on this.
Oh, good, good.
And this was not planned. How wonderful.
No.
But what I want, because this is a very common question that comes up. We don't do all this for flu. We don't make such a big deal of this for flu. But of course, remember that for flu, many people have had Tamiflu. If you have symptoms, you take Tamiflu early. You're not going to get as ill. You're not going to get as sick. We have vaccine for flu. Granted, not as many people take it. It's less than 50%. But that's a lot of people who take it. And we don't have either of those for COVID. We have nothing. But what I want you to see is, if you can look on the left side of this slide, you can see the cases for both flu and for COVID. And I want you to note that the first, and you also have the deaths. I want you to note that the first, it's the yellow, the 65,000, for the COVID, 68,000. That was in just 15 weeks. And if you look down at flu, we're at 61,000. That was for a 30-week period. So in half the amount of time, you had more deaths from COVID. And then what I've put in red is just the remarkable increase from May till July 24th in terms of the number of cases and the number of deaths. It's doubled.
One of the things I always point out, and I may be wrong about this, but to me, the comparison doesn't even make sense, because people are dying, and that means more people are dying. And it's not a race as to who's going to kill, which disease is going to kill the most people. It's an additional way of people dying. Therefore, we should take precautions. That's just my logic.
Well, I sort of think of it this way, and I did mention this to you. I'm a retired Army reservist. Many people may not know that. I was activated for Desert Storm. Both my brothers, Marines. I've been bred on the belief that the strength of America is having each other's back. And I believe it, and I believe that is a patriotic stance. I've lived it. And so wearing these masks, we're staying 6 feet apart, is how we have each other's back. And
I appreciate you saying that, because I have some questions I want to ask you about the masks. I'll talk about that in just a minute. One more question about the virus itself. So a lot of young people don't even know they have it, or when they do have it, the symptoms are not that bad. And I know we know people with pre-existing conditions or have a tougher time. But I have talked to some really healthy folks who've had it and said it was much worse than the flu, that the effects. Can you talk about that a little bit? Yeah, I'm not going to say older, Mayor, because you're not old. But I'll beg to differ. Okay. The younger population does not seem to get as ill. However,
they are definitely going into the emergency rooms more now. And even at Chesapeake Regional, they've seen a reduction in their median age of emergency room visits. Not all COVID, I'm not trying to say that, but from 48 to 38. So we're definitely seeing more of the young people feeling sick enough to go into the emergency room. But it is certainly true that those individuals who are older, who may have comorbidities, a greater chance of comorbidities, are going to be sicker. And a lot of that is because, especially as you get older, the main impact relates to the lungs, and it can occur very rapidly. And as you get older, I mean, you've had more use of your lungs, so your lungs are more vulnerable, even without having, say, chronic obstructive lung disease or any other kind of pulmonary or immunodepressive type disease. So yes, older folks, older being over 49, do get it more severe. But we are certainly seeing there have been deaths, younger population, but the younger don't get as sick generally, but it is like the flu for many. Some of it can be just mild. You've heard of people who have the change in their taste or their smell. Some people may just have diarrhea. So that's the strange thing. This is really a totally unique virus, and this is why I know it was confusing for people, say, at the beginning when we said wear a mask if you have symptoms. And that was based on every other communicable disease we have. We have absolutely no communicable disease that has 40% of people who have it, who are positive, who are contagious and can spread it, who have no symptoms. We have nothing comparable to that in any other communicable disease. We certainly have what's called a pre-symptom period, say flu, 2 or 3 days where you can spread it before you have any symptoms, but 40%, generally in this younger population, can have it, they're spreading it, and no symptoms.
So you mentioned earlier about the hospitals being overwhelmed or getting to that point. They're not at that point. So I heard from Centera and from Chesapeake Regional leaders that one of their major concerns at this point is that the areas of the hospital they have designated for COVID are filling up, which means they're going to have to expand, which means they will be doing fewer non-emergency surgeries. And that's a tough position for them financially. And also, when you say non-emergency, I mean, some of these surgeries are things that you would want to have surgery for. Can you speak to that?
I will say, and again, all of the hospitals when we first had the pandemic and we recognized we were going to have to plan for the future, for any kind of future problems, I know that all the hospitals, I know specifically for Chesapeake Regional, because in our unified command, it was a part of the planning for emergency planning. There are plans in place of where they might be able to send patients who are not at high risk, maybe it was step down or different non-high risk areas, where they may send patients to open up more space so that they can accommodate that. Because I agree, yes, we're classify some as non-essential or non-emergency, but it can be certainly a matter of comfort, can be a matter of work, to be able to have reparative surgery for a number of things. But I don't know that any of the hospitals yet are looking at those plans that are in place, were developed. I don't know if they're looking at any of those plans yet, but that has certainly got to be on the plate.
So let's talk about masks for a minute. Someone said that this is the year of the mask, and there's certainly it's a topic on everyone's mind. There's no shortage of opinion. I put a personal a post on Facebook on my personal website or Facebook page that said, let's wear masks. Had 200 comments, more comments than people like. Usually people just like it or don't like it, but this was such an emotional issue, everyone wanted to speak on it. Not all of them talked about the mask, other people talked about other things that I tried to go away from and keep talking about the mask, but it is, to me, a lot made out of something that is pretty simple. And as you said, we've got each other's back, and so it seems to me like the right thing to do. So how often should we talk about the mask for a moment, and then I'll ask some specifics.
Yeah, sure. And we have to put the cloth and the surgical mask in proper perspective. They're different from the N95. The N95 is 95% protective for both viruses coming in, well, not just viruses, but germs coming in and germs going out. And those are fitted, they have a tight fitting around your face. And so those are certainly what all of these healthcare providers wear when they're caring for individuals who are COVID or possibly COVID. These masks, surgical masks or cloth masks, they've done some amazing laser type photography that has, I think, is very compelling evidence when you look at the photography of just talking, singing, talking at different tones, you know, calling your kid in versus just talking to a companion nearby, where they have seen the droplets with this laser photography. It's just fascinating photography. And then they put the mask on, do the same tones, the different levels and the singing, and it reduces the germs going out of the mask. So the difficult kind of twist, we think of a mask as helping us directly. The truth is, this is just like the surgical team. They wear a mask not to protect them. They're not trying to protect them from germs that the patient are spreading. They wear a mask to protect the patient from the germs that they may be spreading, from having staph or other kinds of infections. And that is the point of both the cloth and the surgical mask. And that's why I say having each other's back, because it's a little bit different than the N95. It reduces the amount of the COVID in the environment. And this is a heavy droplet, so it generally drops in 6 feet. It can go a little bit further, but isn't going to be viable or in large enough concentration to generally cause infection. But the mask is very effective at reducing those droplets from going from you out in the environment. So just even mathematically, the more people who wear the mask, the less virus you have in the community, especially since 40% may not even know they have it. And by having less virus in the community, that's going to help you.
So, you know, I think as a country, we're just not accustomed to wearing masks, and it's an awkward situation. I know I've been in situations where I wish I had it on. I went to an event, and there were probably 20, 30 people there, and it was right at sunset, and you could see when people, if you're at the right light, you can see it. And I had the mask in my pocket. I wanted to put it back on, but most people didn't have it on, so it was very awkward. So I think the more we go along, the faster or the easier it is just to put that thing on and feel comfortable about it. So cleaning these, so how often or?
Well, of course, the surgical mask, you just use
Right.
it, throw away, and get another one. Sorry. Of course, the surgical mask, you just use it and you throw it away, like I won't use this one beyond today. The cloth mask you should clean. I clean mine on pretty much of a daily basis. I have several that I use. They definitely need to be cleaned. A lot, if you can stay 6 feet, I confess, because the masks are uncomfortable. Mm-hmm. I'm not a surgeon. I'm not used to
We took it off to talk now. We're 6 feet apart.
Yes,
Yeah,
right. But we took it off because we're 6 feet.
Right.
And I'll be the first to admit, I have it, it's like my new necklace at work. So it's with me all the time. But I may be talking to my assistant, and I'm standing in the hallway 6 feet from her. So, but my mask can then be off because I know that the droplet doesn't go that far. So it's a combination of the 6 feet and the mask. When I go to some place like Lowe's or some other store, I wear the mask because maybe I'll need to ask a salesperson for assistance, or I may see a friend and I'm going to chit-chat with the friend. When I go out to eat at a restaurant, actually, I prefer sitting outside. So it just makes it easier.
So a lot of people are, I think a lot of businesses are encouraging their folks to wear them because they know it's going to protect their business. In fact, the governor has mandated, and I think we're taking some actions with the ABC board to shut down. How is that going in Chesapeake, by the way?
Well, as you know, we really focused totally on the art of persuasion, but the art of persuasion wasn't as effective as we had hoped initially, because there was some question about our real authority on this issue of masks. It wasn't a part of the regulation and as an executive order, but that authority was strengthened. And so we combine with the ABC agents because they have more experience in this kind of what may be controversial or not well received kind of closures. We always work first on trying to just correct the problem. And I'll go with creative solutions. I'm an out-of-the-box thinker, and if you can come up with creative solutions and it fits the 6 feet or fits the capacity issue, I'm for it. I don't care how crazy it looks. We want to have something that's protective, but we want to also have a viable economy. I have an MBA. I understand the economy. I want us to thrive. And we will thrive best by keeping this virus load down. That's what right now is causing a hindrance, is that it's going up. But now that we have a list of where there have been complaints, and we do follow up very closely now in conjunction with the ABC agents who go with our employees to these facilities, and they only go with after we've already tried the art of persuasion. So we always go first, walk through their facilities, see if there are ways that they can make adjustment, try to educate them to the value of it, and how it will help them if they don't have to close or have any outbreaks in their employees.
Now, I think you told me a week or so ago when you first started going into these places, vast majority of businesses are doing everything they can do with the mask and so forth, correct?
Yes, the vast majority are. We've only had to close, and for a relatively short time of closure, about 2 or 3 locations, and yet we've certainly been to a number of others. The vast majority are eager because it's their business. They want to continue their business, and because we don't just go in with a big stick and say you're closed. Our staff knows very much that our philosophy is we try to help keep them open in a protective way. So yes, the vast majority are very responsive. There are some who are resistant, and we've had to close. But then they come back within 24 to 48 hours at the most with a very good plan, well-thought-out plan, and then we're able to open them. Of course, we follow up with them to be sure that it continues and the oversight. I know it's hard for businesses because they're not in the business of policing their customers, so it's a whole reversal of their role. So I do get that, but everybody wants them to stay open. We just have to figure out the best, safest way to do that.
Now, there are some exceptions. Some people don't have to wear them because of medical conditions. Is that correct?
You're right. That's kind of a little tricky thing because they also don't have to show proof of it. But the reality is there are very, very few people who medically really don't have to wear it. But it's something that does not require a note from the physician or anything of that sort. So sometimes it's overused.
Right. I've quoted a friend of mine who was my assistant principal back in the day who said, a rule that you can't enforce is not a rule. And so it seems to me that needs to be tightened up a bit. So let's don't let time get away from us before we talk about the schools. Last night, the school board made a very difficult decision. You were there, you talked. Can you speak to their decision?
Yeah, I will have to say that I'm glad I'm in public health and I can afford to have a biased view that just looks at health and safety. I would not want to be on the school board. It is a very, very, very difficult decision because, of course, they have to look at far more than just my parameters. I'm focused on the health and safety of the population. But they have so many other parameters, and there was a lot of good discussion, and they did decide based on a lot of the data that I just shared on the slides and on our increasing rate that, of course, they have the 2 options, as you know, and those who choose online, that's not even an issue, but those who are in that option number 1 where it has that spectrum from traditional and hybrid and then temporary online because of what we call our virus burden. And that's sort of how we define those increased rates of cases and positivity. Because that is so high right now, and not only in Chesapeake, but in the eastern region, a lot of the teachers certainly live outside Chesapeake. So we are the #1 hotspot right now in Virginia. And so based on that, a decision was made for a temporary online. Now, a key to that is going to be following data. I'm a data-driven person. I just have to use that as some objective mode to make a decision. And so we will be following positivity rate, and we'll be following, like that first slide I presented, that is the average weekly caseload per 100,000 population. You saw from that first slide, it had gone up to 190 some. It's now down 160 some. And we've established that if it's over 100, that's a high burden. If it's between 10 and 100, that's a moderate. If it's less than 10, then that's low. Obviously, it is still high. Now, what will I do with it? Well, here's the other reality. As I mentioned earlier, the younger children do not seem to be the transmitters. They do not seem to be the spreaders. They do not seem to get the disease in the same consideration as others. And having 2 children myself, I certainly understand and attest to those first several years are most important. That's where you develop the love of learning. And if you have the love of learning, the rest is easy. So it's developing that love of learning, and that can only come from face-to-face. I recognize that. And the special needs, both my kids receive special needs assistance. Could not have done it without it. That's extremely important. So when looking at the data, and again, we're just going to have to see what the trends are. It's not just a one point in time. It's looking at the trends. If that, I hope it's a continuing trend, where it went from 190 to 160. If that continues to be down, then I would be open, quite frankly, depending on the rate and how much is going down, I would be quite open to considering for those younger children, since they are at less risk. It's really the adults we have to be sure we use the protective measures. But for those children, if there'd be a way to get face-to-face for them. I'm a pediatrician. Also, I want those children to be educated. I know there's a difference in how they learn. And I could never be a kindergarten teacher because they're bouncing around all the time, but they're the ones who develop the love of learning. So I would be up for considering that. Now, for the older age, I think we're going to have to look at more statistics on that.
It's really interesting. I think again, opening schools affects so many different things. Businesses, people being able to go to work, kids' education, I mean, just a myriad of things. And so that's why it's such a big issue for people. But you need some guiding principles. And I'm glad to hear that there is such thing as a metric in which you can determine the degree of risk versus reward. Because I think we're all affected by what's personal to us. I have a daughter and 2 grandkids, and then she goes back to teaching. I can see that affecting them. So I would be probably more leaning towards closing schools based on my personal experience. But the fact that you're using a metric that doesn't consider your personal circumstances, at least it's a good guiding principle to make recommendations from. So I'm glad that you have that and use it at your disposal.
And let me also say that we've been successful in getting approval from the state for us to have a an additional full-time epidemiologist. And that epidemiologist will be devoted entirely to schools, public and private, and child care centers, because of course that's involved when you open up more. And we will be working with training and having the school nurses be engaged in contact tracing. So we'll almost sort of develop our own work group right there, led by the epidemiologist who will be devoted to the schools, because we have to be prepared for changes.
Right, and that's one thing the last 5 months have taught us is is being prepared, knowing when to step out, when to step back in. So that's good. So here I'd like to think that we're coming to the conclusion of, we've been in this 5 months, but we just don't know. We may even not even be halfway there. What do you see on the horizon?
I said this on the very first roundtable we had, Mayor, and I'll say it again, it depends on us. Mask and physical distancing, and I do prefer the term physical distancing, that's all we've got right now. We don't have a vaccine, we don't have meds. We have our behaviors. This is a behavior-controlled disease right now because we don't have vaccine or medications. It is totally contingent on our behaviors. And yes, the behaviors that make a difference are uncomfortable. Not having the mask, not being able to hug folks who, I'm a hugger, who are, it's difficult. For folks who are introverts, they're loving it, but for others, they're not. I understand that, but this is a behavior controlled. Wearing a mask is inconvenient, but it makes a big difference. Physical distancing is perhaps annoying at times, but it makes a difference. So it really rests in our hands.
I really want to thank you for being here today. I know that, like I said to you earlier, when you give information that people don't want to hear, they question your source. One of the things that I've been able to see is people will send me articles or videos, and the first thing I look at is the source. Where did that come from? A guy in front of the hospital with a doctor's outfit on doesn't make him a source. He could be an actor doing whatever. So the fact that we do look at the science, we do look at the data, and we make those decisions. And you and your staff, I know, have been under a lot of pressure in the last 5 months, and you're doing a wonderful job. And on behalf of our whole city, I want to thank you. So that wraps up this edition of the Roundtable. We will be back to do these roundtables as time or circumstances determine that they are the right thing to do. I am Rick West, reminding you to wear your mask. Now, we have a Chesapeake Cares mask that's a lot prettier than this 757 mask, and there's all kinds of masks that make statements, so please wear your mask, maintain 6 feet distance, and wash your hands and stay safe. Thank you for joining us.